Welcome everyone to our 2026 Know All Your GBM and Recurrent GBM Treatment Options Patient Disease Educational Webinar. I'm Delanne Elliott Midland, and so I am your chairman and CEO of the End Brain Cancer Initiative, formerly the Chris Elliott Fund. And I'm proud to be here moderating this particular webinar with each and every one of you today. Let's get rolling with the program today. First up is Dr. Eric Wong, and he wants you to come away today with 3 points: how to become clinical trial ready, using the Optune Geo device for GBM and recurrent GBM, and he's going to talk about the FORTE clinical trial as well. So I have a little bit of information I also want to share with you about Dr. Wong. He and I met many years ago. I'm not going to date any of us, Dr. Wong, but he used to be at Beth Israel in Boston. And he held the roles of director of the neuro-oncology unit and co-director of the Brain Tumor Center at Beth Israel Deaconess Medical Center in Boston. And I don't even remember, Eric, how we actually met, but I did want to say thank you to you, because I know that over the years we've been able to refer many patients to you, but you invited me a very long time ago when I first started doing site visits, and you invited me to sit at the table with your researchers and your patient navigator and your clinical trial coordinator. I don't know if you remember that.
I don't. Actually, I'm sorry.
That's okay. That's okay. I just wanted to say thank you because it was
You're
such a
welcome.
great conversation.
I see.
And it is incredibly meaningful for my team and I to always meet not only you, right, the specialist, but to also meet your team that helps you with the patients that you serve, because that helps us when we have those kinds of relationships with all the other people. We're able to move patients faster and quicker into specialists' hands and into advanced treatments and advanced diagnostics and clinical trials. And so those meaningful relationships are super important. And, back in the old days, we didn't really use Zoom or
Right,
Teams or things like
right.
that. We met in person, in real life. And so I just wanted to say thank you.
Well, Delanne, I just want to say that the first time that we met was actually when Novocure was presenting data to the Food and Drug Administration. That
Uh,
was back in 2011, 2010 and 2011. And Food and Drug Administration wants to hear, not just from the doctors, but they want to hear from patients advocacy groups, because how new therapies will impact their lives. Okay, I think Delanne was there in the panel meeting in Rockville. I was one of the presenter of scientific data, and there was a patient who looked like you, Mandy, wearing the Optune device and standing in front of the Food and Drug Administration's reviewers and tell him his story. So your input is absolutely important.
Absolutely. Thank you. And he's talking to you guys, right? He's talking to you patients and caregivers and family members. And so we try to open up opportunities to hear your voice, just so you know that. And then I know that the End Brain Cancer Initiative works really, really, really hard to insert your patient voice not only into FDA hearings, but also documentation that the FDA requires, et cetera, but also into clinical trial protocol development, also into educational materials, things like that. So we are listening and we are sharing. So thank you. Really quick, I'm going to introduce Dr. Eric Wong, and then he has an amazing presentation for us. So get ready. Dr. Eric Wong is an authority on advanced treatments for glioblastoma and is the director of the Medical Neuro-Oncology Service at Brown University Health Cancer Institute. He is a professor of neurology, medicine, neurosurgery, and radiation oncology at the Warren Albert Medical School of Brown University. He brings extensive knowledge and research experience that focuses on device and drug therapies for primary malignant brain tumors, imaging of neurologic malignancies, and management of, oh, I never can say this word. Can you help me out? Leptomeningeal.
Oh, leptomeningeal
That one.
metastasis.
Metastases in the central nervous system. In the past 2 decades, his work has led to the development of innovative cancer treatment technologies and simultaneously transformed the management of brain cancer by oncologists. And thank you, Dr. Wong. He earned his Bachelor of Science degree in electrical engineering from the University of Pennsylvania and a Doctor of Medicine degree from Rutgers Robert Wood Johnson Medical School. He pursued an internship in internal medicine at Rutgers, New Jersey Medical School, followed by a residency in neurology at Barnes Jewish Hospital, Washington University School of Medicine, as well as fellowships in neuro-oncology at Memorial Sloan Kettering in New York and the University of Texas MD Anderson Cancer Center. Wow, I did not realize all of that. You are very, very experienced, sir.
Well, I was traveling all over the country.
Wow. Wow, you were. You were amazing. Okay, it is your turn to enlighten us, Dr. Wong.
Okay, well, thank you very much, Delan. That was a very kind introduction. And this is a privilege to tell you what excites me every morning, and that is to help glioblastoma patients, okay? How I can help glioblastoma patients. Here are my disclosures. What I would like to do today is three things. One is to emphasize that molecular testing is important. Do not overlook the benefits of tumor treating fields, because the reason why I say this is because I ran the very, very first tumor treating fields clinical trial, and that was in Boston. And basically, my colleagues were looking at me, Eric, you probably watched too many infomercials in late evening, probably. And frankly, a lot of doctors, oncologists really did not think that this was a real treatment for cancer. And as I will tell you, this is not just for glioblastoma. This is also for other malignancies. And then the third thing that I would like to be aware of is that while you are in search of your next clinical trial, looking at the upsides of treatment options, keep an eye on the downsides. Okay, this is very important. So I just want to point out this pair of painting, because this pair of painting is at the lobby of this hospital at Rhode Island Hospital. This pair of painting was done by this husband and wife team who is 15, 20 minutes away from Providence. They were living in Attleboro, Massachusetts. And they also painted a very, very famous painting of the first ether used in Boston. Okay, this pair of painting was done to commemorate 150-year anniversary in 2013. And on the left side, you can see a scene that was dated back to 1860s, in which you can judge from the attire that they were wearing something from the 19th century. It is an evening scene. There's a patient there, and it's quite gloomy. On the right side, it is in the modern era, in which doctors wear white jackets, the scenery is bright, okay? So there is a transition from the dark ages into enlightenment. So that's what the message subliminally that is imparted to the person who's watching this pair of painting. But I want you to pay attention to the emotional valence of the two children that are there, because they are staring at you. On the left, this little boy is looking at you, and he's like, wow, he cannot tolerate this room because something that looks like is making him sick. The girl on the right-hand side, however, looks kind of bored, and she's asking, and she's like asking you, okay, when can she go home, or when can she go out and play with her friends? Do you know why? Because the diseases are very different between these two periods. This is a disease that were recorded in the state of Massachusetts from 1840 to year 2000. And as you can see, In the 19th century, most of the diseases are infectious disease. So most of the patients who are hospitalized have an infection of some sort. And obviously, that boy from the painting on the left, he was probably sickened by the stench within the ward. Okay. Whereas in the year 2000, cancer and heart disease surpassed infectious disease. Of course, there was the Spanish flu from 100 years ago in 1918, in which this flu virus caused a pandemic. And we just went through another pandemic, and that was a COVID pandemic. Unfortunately, the epidemiological statistics didn't go as far out, but I'm sure that there will another peak of increase in death toll in year 2020. Now, why am I pointing this out? The reason why I'm pointing this out is because in the millennia of evolution, our body is evolved to fight off infections. Our body is not evolved to fight off cancer. So this is the reason when infections comes down and as we live longer, the cancer incidence increases over time. So yes, I want to use this picture to draw the analogy of upside and downside. Keep pressing and you will see an up arrow. Yes, we want to find therapies that works on your tumor, but you also need to watch out from therapies that may counteract some of the treatments that you are getting. So I will talk about three things. One is plexorafenib, which is a FORTE A394 small molecule inhibitors that is primarily for IDH-mutant glioblastoma, but it will also block other types of tumors harboring a specific mutation or fusion. I will talk about Optune, in which it will also work for IDH wild-type glioblastomas. And on the downside, I would like to talk a little bit about the dexamethasone, which is something that I stumble along in the past couple of decades of clinical research that I come across with a realization that one has to keep an eye on the dexamethasone use. As you know, BRAF, you probably hear it from talking to cancer doctors. BRAF is a very, very important protein that transmits signals from outside the cells to the interior of the cells and trigger a program to tell the cell to divide and multiply. This is in every single cell. This is very, very important when we were developing in our mother's wombs, but it is also important and it is ready to be utilized put into motion when there is a perturbation in our system. So for example, when you have a cut on your skin, there will be a signal that is transmitted from the surface of the cell through BRAF into the nucleus of the cell and tell the cell to divide and to heal the wound, okay? However, BRAF, and this is the protein right in the middle, however, BRAF can turn RHO, okay? And the way it can turn RHO is because of mutations. Okay, so on the left side, you can see that there are growth factors that are triggering the signal going through the BRAF into the interior of the cell. However, when there's a mutation, and in this case, it's called V600E, because of one amino acid change in the protein, that's enough to make it turn RHO. Okay? And then it becomes on all the time. So it will tell the cell to go ahead and divide, and non-stop. And what you have is a clone of cells that have this mutation. And then in this particular case, it is melanoma on the right-hand side. And then the melanoma will eventually acquire additional mutations that make it malignant and metastatic. So in our body, BRAF mutations can be found in various types of malignancies, most commonly in melanoma, occurring in about 35% of the time, in thyroid cancer, about 44% of the time, but in gliomas, it occurs in about 11% of the time. This is primarily in children and also younger patients. Okay, so this is the reason why I asked about next generation sequencing and molecular sequencing of your tumor, okay? Particularly when you are under the age of 60. And I think it would be very, very worthwhile to have a conversation with your oncologist to say that should we send your tumor to Carrots life sciences for sequencing or Foundation Medicine for sequencing. And these are the two major tumor sequencing companies that will take your tumor block and then isolate the tumor cells and see whether or not there are specific mutations there. Now, there are also BRAF fusions, meaning that one piece of the chromosome where BRAF resides breaks off and it fuses with another piece of the chromosomes. The chromosomes in cancer cells are very fragile. What happens is that one piece can break off and refuse with another piece, okay? However, when the fusion piece is just right, it can promote a growth signal. So it doesn't necessarily need to be a point mutation. It can also be triggered. The growth can be triggered by a fusion product. Now, a lady named Karen, asked, how does MSKCC's report compare to Caris? I would say it is comparable. It is comparable. However, MSKCC is the in-house molecular testing, okay? There are certain hospitals that have their own next generation sequencing program. However, it's not like these companies who just dedicated all of their resources to improve the next generation sequencing. Yes, I have seen some of the MSKCC report. They are pretty good, okay? But as time go on, they may diverge, okay? Because MSKCC, they have other missions, okay? They cannot concentrate all of their resources into just this type of molecular sequencing. But these two companies, they are concentrating on all of their resources. They're constantly improving them. You may want to talk to your oncologist about whether or not it is appropriate to send it to those companies as well, okay?
Dr. Wong?
Yes?
May I interrupt just a minute? This is Delanne. I would say too, when you're speaking to your oncologist and your neuro-oncologist, that you need to ask for your comprehensive genomic report. A lot of times, and you, Dr. Wong, you probably know this is true, Dr. Wong, when places have their in-house comprehensive genomic testing in-house, they do not always share that information with the patient. So ask for the report, and I would say demand the report. If you need help reading it or interpreting it, Shreya, our patient navigator, can help you. She's well versed reading those reports, as I am as well. But there are keys to how to treat your exact tumor in those reports. So be sure, one, you get the report, and two, Dr. Wong's messaging, outside testing companies are very, very meaningful to you as well.
I just want to add that I think it would be prudent that you ask a second opinion, right? So you go see a doctor for a second opinion. Well, you can ask for a second opinion on your genomic profiling report. Okay, you can ask the LAN, you can ask other the physicians that the LAN associates with. Okay, so the LAN's organization can certainly help you.
Mm-hmm.
Okay. These dots, the size of the dots tells us the proportion of the genetic abnormality. So in gliomas, they profile 2,664 and approximately 132 had these changes, and the majority of them has to do with the V600E point mutations. But however, can you press the return button again? There's also fusion there. Fusion is the next largest genomic abnormality other than point mutations. So this is something that's very, very important to know. And the genomic profiling report may not have the fusion. So you may need to get the fusion done separately through another institution or ask the same molecular profiling company to perform a fusion study. Okay, so this is something that is very, very important. Now, this is important because plexorafenib or PLX8394, and now it's called FORTE 8394. This is a drug and what we call small molecule, and these are all chemical structures, and you don't need to know the chemical structures, but I just need to show you that there is a variety of chemical structures just for targeting this rho protein. Okay, so press return again. So this is the structure for A394. Again, what this molecule does is that it fits into the enzyme and locks it, okay, and make it non-functional. So here's some clinical data on how this drug works. And on the left side, this is a grade 4, WHO grade 4 astrocytoma. It is called an astrocytoma now, not called a glioblastoma now. And this patient was treated with temozolomide and concurrent with radiation, followed by adjuvant temozolomide. And then the patient was treated with plexorafenib and clobetastat in 4-week cycles. And the patient was able to get a partial response and eventually a near complete response. On the right side is a 37-year-old man with a recurrent V600E positive central astrocytoma. A little bit different. This is not a glioblastoma, but still, it is a fast-growing tumor, and this patient had a great response to the treatment. So the clinical trial is still ongoing. You can go to clinicaltrial.gov. For those who don't know about clinicaltrial.gov, ask the LAN, and the LAN staff will certainly show you how to get to clinicaltrial.gov. And you can put in the information, and it will also show you the rationale, whether or not the trial is still active, enrolling patients, whether or not it's phase 1 or phase 2, and where it is. Okay, so this is a multi-center trial, and my institution is participant. And so it is in the state of Washington at the University of Washington School of Medicine. Okay, so it's all over the country. In fact, it is all over the world. So if you happen to live in Australia, yes, there's a site. There are 5 sites in Australia. Okay, so you can go on to clinicaltrial.gov or you can ask the LAN. Okay, so the next thing that I would like to talk about is the tumor treating fields. So let me just put it into perspective, okay? Because tumor treating fields is a physical modality of treatment. The closest thing to it is radiation. So as you can see on the right-hand side, you have the word ionizing radiation. That means high energy, high power type of radiation. But tumor treating fields is not like that. Tumor treating fields, you can use it at home. You don't have to use it at a facility. And I can see a number of individuals in this call who are using tumor treating fields, okay? It basically uses radio waves to treat tumors, okay? And the way that it come about is because of this professor, Yoram Palti in Israel, in Haifa, Israel, because he was curious about whether or not radio waves has an effect on cultured tumor cells. And he testing it in the laboratory, and he saw some effect. And here's the timeline of development, okay? So the initial observation was in 2004. The first clinical trial was put into motion in 2007, and I participated in the first clinical trial, okay? And the first approval for recurrent glioblastoma was in 2011. And then for newly diagnosed glioblastoma was in 2015, but it didn't stop there. So this is the first approval from the FDA letter, and that was on March 18, 2011, but it didn't stop there. It is now approved for use in non-small cell lung cancer after platinum failure, okay? Advanced non-small cell lung cancer. And not only that, from last year, from earlier this year, that FDA approved it for the treatment of advanced pancreatic cancer. So it's not just glioblastoma, it's for non-small cell lung cancer and also for glioblastoma, okay? So these 3 indications really solidify this treatment as a important modality for cancer treatment, okay? So this is the reason why I ask, please do not overlook this life-saving treatment, because sometimes when I present this treatment to patients, they said, what? I had to shave my hair off okay, particularly women, okay, they always have that reaction, and sometimes men, okay, and they also would have reservations because they have to wear this box 24/7. But I told them that if they bank their hours, they can have a holiday, 1 or 2 days of holiday, if they can bank it that way. So that's FDA approval, right? But whether or not insurers will cover it is another story, okay? And it takes another 10 years in order to get into the national coverage decision, national coverage determination for Tumor Treating Fields. And I meet with the Massachusetts Blue Cross Blue Shield every year, and this is public information. Their medical policy is searchable on the web. This major insurer is covering it. Okay. So if you have any questions, you can certainly talk to Deland and any of the advisors on the panel. So this was the original video that was taken by Dr. Pulte, and you can see that the tumor cells kind of blow up, and the clock is an hour. It is speeded up a lot. And on the right is my former patient who was featured in the Boston Globe, and he was able to use it for 7 years. Okay, so this really, and he was working as an engineer in Waltham. And the reason why he adopted this is because he was an engineer. He understood the engineering. He understood how it may work. It kept the tumor at bay for 7 years. This is how it works. Okay, so the electric fields have charges, and this really give alternating electric fields. If you have children, you take your children to a children's museum, and they put their hands on the Van de Graaff generator, and their hair would stand up because there's an electric field around their head. Okay, and what happened is that this tiny electric fields lifts up their hair. Okay, and that is what the tumor treating fields is doing on your scalp. Okay, Mandy, I see that you wear this. Okay, the electric field is going into your head, and it is causing some mechanical disturbance on your tumor cells. Okay, leading to chromosome disruption, protein dislocation, and so on and so forth, that I won't go into. But that's the basic mechanism, is that this electric field is transformed into a very tiny bits of energy that mechanically disrupt certain critical functions of the tumor cells. So, and it is frequency specific, okay? Because the operating frequency is between 100 and 300 kilohertz. That means you add 3 more zeros after those numbers, okay? And at this frequency, it is basically lower than AM radio waves, okay? But the point is this is a specific frequency band, okay? This doesn't operate outside when the frequency is higher or lower. It only operates at those specific frequencies. If you want more tutorial, you can watch the movie that I made when I was at Boston Beth Israel. Okay, it's freely available on the web. It is called The Clinical Application of Tumor Treating Fields in a journal of, I think it's called Jove.com. Okay, it is a video journal. It is a video scientific journal, and it is available on the web. So Karen, you asked a question, can a pregnant woman wears it? I think the tumor treating fields, this is the reason why you have to shave your head and wear it, because it doesn't transmit from the top of your head to your abdomen. So it has to be very close to the proximity. So patients with lung cancer, they would have the pads on their chest. Patients with pancreatic cancers, they would have the pads on their abdomen and the flank area and also the back. So I think for a woman who is pregnant with brain tumors, it is certainly safe, in my opinion, to use it, but make sure that you check it with your treating oncologist just to be sure. In that video, I talk about these tumor treating fields arrays. So the initial set of arrays are rectangular, but now they have a new array. And in the video, I show how to put the array on a real patient, okay? And the new arrays is circular, which is smaller size, packs a lot of energy, so a lot easier to use. In order to see the effect inside the brain, we cannot take a picture of it. we have to do something that's called electrical modeling, in which my research team does a lot of this. We have been doing it for about 15 years now. So you can see that the scalp is very, very hot. Okay. So those dark red areas basically is packed with energy around those electrodes. And on a hot summer day, and in F, that was taken from one of my patients during the summer, during a humid day in summer, and there were these red marks there. Now, when I first started using it, a lot patients asked me, and also certainly my colleagues asked me, well, if this is causing disruption of tumor cells or fast dividing cells, how come I don't see hair loss? Well, we do see hair loss. This is from a patient who have been using Tumor Treating Fields for over a year. So when she decided to take it off and let the hair grow back, and those areas where the discs are placed consistently, basically she lost hair. It's not permanent, and eventually those hairs will come back. Okay. So here's the survival curves, and as you can tell, the blue curve is on top. Those are the patients who use Tumor Treating Fields in addition to temozolomide after radiation. So it basically improves overall survival. It improves something that we call progression-free survival, delays tumor progression. And the side effects are very tolerable. Most of the systemic side effects, the drop in blood counts, the gastrointestinal problems, the fatigues, are primarily from the chemotherapy use. There are specific side effects associated with Tumor Treating Fields, and that has to do with the medical site, device site reactions from the electric fields on the scalp. Sometimes when patient's balance is off, you have to be very, very careful wearing the device, but it is always prudent when your balance is off to have a family member around. Here are some of the additional symptoms in terms of neurological signs and symptoms. Most of it is either from the tumor or from the side effects from chemotherapy or radiation. Next slide. One thing that I would like to point out is that brain swelling can shunt the Tumor Treating Fields away from the tumor. The way that we know this is because my research team has been addressing this question, okay? So you know that glioblastoma has edema around it, okay? And unfortunately, the edema is conductive. And you see that arrow from the surface of the scalp? That arrow, the electric fields has to go from the scalp, past your dura, past the CSF, get into the brain, and to be at your tumor. So, however, there's a layer of cerebrospinal fluid that is between your dura and your brain, and also inside your brain. So, if you have a lot of brain swelling, you have to find a way to reduce that swelling in order to allow the fields to get at your tumor. Okay, there are only two major drugs that treat this swelling: Decadron or dexamethasone, or Avastin or bevacizumab to treat it. And there are pros and cons of either medications. So one has to be aware. So talk it over with your oncologist about how to reduce brain swelling to allow better penetration of Tumor Treating Fields into your tumor. There's also another thing, and that has to do with my team's reanalysis of dexamethasone use in the EF11 trial that utilized Tumor Treating Fields. And we found that when patients use high doses of dexamethasone, high, I mean using more than 4 milligrams a day, it reduces their survival. Okay? Not only in the group of patients that use Tumor Treating Fields, but also in the group of patients that use chemotherapy alone. Okay? So in other words, dexamethasone can potentially interfere with cancer treatment. This would be a good segue into my last part of the talk, which is the downside of your search for treatment. Okay? Yes, you want to look at what is the next clinical trial that you can participate in. Yes, you are adopting your standard of care treatments and you try to maximize it, but don't disregard the downside. A good analogy would be, look, you can drive at 100 miles per hour to get to your destination sooner, okay? But you have a higher risk of crashing, right? You always need to keep an eye on the downside. And one of the downsides that we found in our research is dexamethasone. Now, this is the original bottle from Merck that made dexamethasone. At that time, it was not just Merck, it was called Merck Sharp and Dome. It is in the Smithsonian. Okay, so when you go to the Smithsonian, you may see this. Okay, so look at this paper. It was published in 1961. Okay, I wasn't even born then. Okay, the first clinical trial was performed by this neurosurgeon named Joseph Galicic as the first author there. And I had the opportunity of meeting him when I was at Memorial Sloan Kettering Cancer Center. So he was the first one who used dexamethasone, and he saw a dramatic improvement in the patient's state. And that was a godsend at that time. That was a major, major improvement. But at that time in 1961, there was no CAT scan. There was no MRI scan, and they were only able to use skull X-ray and angiogram in order to see the effects, see the improvement. But dexamethasone also has a plethora of side effects. And you probably, for those who use dexamethasone before, you probably experienced some of this when you were using it. It can make patients gain weight and make them develop moon faces. And on the left, there's a child with basically this physique after dexamethasone use. You have to use it for a period of time, probably about 2 to 3 months, depending on the dose. The higher the dose, the quicker that you will achieve this state. But there are additional side effects, such as induction of diabetes. It can cause high blood pressure. It can make you gain weight. It can make your muscles weak. It can cause osteoporosis. It can make your wound heal poorly. It can give you fat pads behind your neck and also your face. So be careful about dexamethasone. I'm not saying that you should not take dexamethasone. I'm just saying that you should take dexamethasone judiciously, use the minimum dose for your symptoms, and speak to your oncologist who's managing your dexamethasone. Also, another thing is that when you're on dexamethasone, you feel euphoric. You have a lot of energy, okay? So you can do a lot of things, and therefore you don't watch this because you feel great. You don't call your doctor, okay? We have our staff to monitor patients on dexamethasone use very, very closely. So dexamethasone is a fluorinated steroid, just like your testosterone, your estrogen, okay, it's along those lines, but it's a special steroid. It has a fluorine in it, make it smaller so that it can get into the brain better. And some of the side effects was investigated back in the 1970s, okay? The first person who was studying this was Dr. Fauci. Guess what? When he got his first job after residency, that was his first job at the National Institutes of Health. He never left, okay? And his first study was on the dexamethasone side effects on the immune system, and specifically on the lymphocyte function. And as you can see, after a dose of dexamethasone in healthy volunteers, the lymphocyte count drops within 24 hours, within about 6 hours. And then the lymphocyte counts recovers within 24 hours. Now, in 2016, there was a large-scale retrospective study that was done looking at dexamethasone effects in 3 major databases from MSKCC, from the European Organization for Research in Cancer, as well as the GGN, or German Glioma Network. And all 3 databases show that the black curve are patients who use no dexamethasone, whereas the red curve are patients who use dexamethasone. And there's a survival difference. And more importantly, they went into a little bit more detail in the German Glioma Network and looked at patients who had gross total resection of the tumor. In other words, everything on the MRI scan was taken out, okay? And whether or not dexamethasone has a negative effect on the survival and progression-free survival. And the answer is yes. Now, it begs the question, These patients, the tumor was taken out. Why are they on dexamethasone? Right? Okay. So I can think of only two things. One is that when you are dealing with glioblastoma, the glioblastoma is very infiltrative. There could be hidden tumors that the surgeon cannot see. Okay, well, nowadays we have 5-ALA. Surgeons can use these dyes to get a good resection. Okay, so things are better. Okay, another possibility is that when patients are on dexamethasone, they feel euphoric, they feel great, they have a lot of energy, so they don't call their doctors. Okay, so when the doctors don't call, nothing wrong. Okay, so they are maintained on dexamethasone. So be careful about dexamethasone. Dexamethasone can have a negative impact on your drug treatment. And lastly, this is a clinical trial that was done in a cooperative group in which using an even more potent immunosuppressant called everolimus. And everolimus is a bona fide anti-cancer drug. But if you go to the web, you can also see that everolimus is also used by transplant surgeons to prevent solid organ transplants, such as liver transplant, such as kidney transplants. Okay. And the reason is because it is a very potent immunosuppressant. Dexamethasone is also an immunosuppressant. And look at the overall survival curve. The dotted line are the group who use everolimus, an immunosuppressant. Okay. It can have a negative effect on their survival. To sum it up, so I talked about Paxlovid, an example of a drug that is in clinical trial right now. That is a targeted therapy that works on BRAF mutated glioblastoma and also other types of intrinsic brain tumor, as well as those that have BRAF fusion. I talked about Optune, how Optune come about, and how Optune has proven itself as an anti-cancer therapy, not just in glioblastoma, but also in non-small cell lung cancer and pancreatic cancer. And I also pointed out the downside of dexamethasone. So you can consider Avastin. Other drugs that can have an anti-edema effect include Celebrex. Celebrex is an arthritis medicine. Losartan. Losartan is a blood pressure medicine, and also a supplement called Boswellia. Boswellia actually was in clinical trial by radiation oncologists, and it has an effect in terms of decreasing the cerebral edema. Okay, even though it is a supplement. Okay, but it has undergone randomized clinical trials. Okay, and I just want to say that in my career, a lot of people supported me, including grateful patients. And the person with the bike is a person named Tom Desfaces, who has been very supportive of my research. And over the years, there are multiple organizations who supported my research, including End Brain Cancer, Marcelo Foundation, Rhode Island Life Science Hub. Can you turn on that video? I just want you to watch this video and perhaps give those in the audience with glioblastoma or other types of brain tumor a word of encouragement. Tell the world, how many years have you been having the glioblastoma?
22-year glioblastoma survivor.
Congratulations, Ed. I'm very proud of you. Well, he will be seeing me next Monday. He's coming to clinic to see me next Monday. Okay? I think this is as much of a home run that I can make. Okay? I have in the past I had 10-year survivors, 7-year survivors, 5-year survivors. Okay? So it is possible. It is possible. Okay? So the key is look at the upside and also watch your downside. Okay? And it's the difference that you want. Thank you very much.
Thank you, Dr. Wong. Amazing. You gave us so much information, and you just spoke to a bunch of people from all over the world today, Canada and Brazil and United Kingdom and California, Boston, New Jersey, Tennessee, Chicago, all over the place.
Wow.
So thank you. Yeah, you There were a lot of people registered today, and so you're speaking to a lot. And as you know, this will become a patient disease educational video, and that is the living asset, and it will be widely distributed by the In Brain Cancer Initiative. So I want to thank you so much for your expertise and your time. There are a couple of questions in the comments.
Hi, Dr. Wong. There's one question that Christian posted. A recent NIH study suggests that testosterone can suppress glioblastoma growth in males. And I asked my oncologist about testosterone replacement to treat fatigue associated with my illness. He was opposed to this because he felt that testosterone may cause tumor growth. This study refutes that. Do you have an opinion on that issue?
I don't have an opinion because I don't think there's any data that I'm aware of that it will make tumor grow or not make tumor growth. However, I just want to point this out that one has to be very, very careful about hormones, because I once had a patient who came from New York City. And in New York City, you know that there are a lot of these health promoting clinics, okay? And one of the hormones that he was injecting himself on was growth hormone. Growth hormone. Growth hormones make things grow all over your body, and he was diagnosed with a glioblastoma. I don't know whether or not there's any relationship between growth hormones and glioblastoma growth, but that really would give me pause in terms of asking for more opinions. I have patients who use testosterone supplement for ED and also for just low testosterone levels. Okay. I think if you just for normalization, but if you increase it above normal, that may be a problem. But I don't have any data to back it up.
Thank you, Dr. Wong. You have lots of people saying thank you so much, Dr. Wong.
Oh, thank you for attending, and thank you. I hope the information that I give you will help you to think about your tumor in a more holistic fashion, okay? Not just focus on one area. You have to look at the entire picture. Okay.
We have a couple of other questions. What's the next step, in your opinion, once diagnosed with multifocal and on Avastin?
Well, I think the next step would be to look for a clinical trial. Okay. And I think everyone would be telling you to go look for a clinical trial. So go into clinicaltrial.gov to look for a clinical trial. And if you cannot find a clinical trial, this is what I would do. I would think about the patient and I would design something for the patient. Okay, so multifocal glioblastoma is not common. It's less than 5% of the glioblastoma. Okay, so Avastin can certainly keep the tumor at bay. However, it's not going to last for long. But there are other strategies in terms of drug treatments on the metabolic side, and these are drugs from the metabolism regulation side. There are devices that may need to come into play if you have oxygenation issues. Okay. So it is very, very important for you to find an oncologist or neuro-oncologist to look at your entire picture. Okay. And that's what I would do. I would design a program for a patient.
Thank you, Dr. Wong. I have a question. When you were talking about comprehensive genomic testing, which we know is important, vital, you also were explaining about fusion and spoke about why it's important to have a fusion test. So I just want to talk about that a little more. It sounds like a fusion test is different and not included in the comprehensive genomic test. Is that correct?
Well, okay, I don't know whether or not MSKCC or MGH or Mayo Clinic, their in-house testing would include fusion. There are certain institutions in-house molecular testing that does not include fusion. Okay. I know that Caris includes fusion. I'm not clear on Foundation Medicine. And now, because of the FORTE A394 drug, fusion becomes important because that drug also works on fuse BRAF.
Okay.
Also work for BRAF fusion tumors. So this is where it is important because you may want to look at specific fusion if there are specific drug for it. So it's not just BRAF that has drugs against BRAF fusion. There's also NTRK, which is another growth signaling protein. I have a patient with NTRK-free fusion, and the patient took a drug called entrectinib, and that worked very well for her.
Okay.
So there are these specific cases for fusion. You should talk to your oncologist and discuss whether or not you should undergo fusion testing. Yeah.
Excellent. The End Brain Cancer Initiative is actually putting together a comprehensive genomic guide, not only what it is, why it's important, how you use it, but in the United States, where you can go to get an actual comprehensive genomic test. So, Shreya, I mentioned this because I think we should include in there about fusion.
Okay. And then
Okay.
Dr. Wong, there was one more question that came in the chat.
Okay.
Karen asked, how many years do you recommend someone wear the Optune device?
As long as possible, because this is how the Optune works, because the alternating electric fields are constantly being there. The tumor cells are specifically very, very sensitive to the Optune electric fields only at a certain stage of the mitosis. I'm sure that a lot of you know what mitosis is. It's when one cell kind of divide into two. It's during a specific stage of the mitosis that the electric fields has the biggest effect. So I think it's very, very important to wear it as long as possible. And also another important thing is that the disruption can make the tumor cells more visible to your immune system. Okay? So you have to wear it as long as possible, and also you have to keep yourself healthy. Get enough sleep. Okay? Drink plenty of fluid. Eat a well-balanced diet. Exercise. The best medicine for your brain, exercise. Okay?
Outstanding. Outstanding. There is a question that's interesting. It says, do you think GLP-1 medications could impact or have caused someone to get glioblastoma?
I don't think so. I don't think so. And in fact, there are certain glioblastoma patients that I give them GLP-1, and I'll tell you why. Because they do not sleep well, they may have snoring at bedtime, and the GLP-1 may decrease the tissue around their oropharynx to make them sleep better. So GLP-1, in my opinion, may be beneficial.
That's interesting. There is another question. There is a person joining us today who is asking this question. What does it mean that my tumor pathology is wild type?
Oh, I see. Okay. Well, the glioblastoma or the gliomas has two major molecular conditions. One is wild type and one is mutated in the enzyme called IDH. IDH stands for isocitrate dehydrogenase. And this is a branch point in which in our classification, because IDH mutant tumors are more commonly found in younger patients, children and younger patients, whereas IDH wild type, meaning that there's no mutation, are usually found in older patients. Okay? The mutant tumors, just because of chance, have a higher probability of mutations, whereas IDH wild type has less probability of having mutations. So I think this is how we classify tumors. It helps us to put patients into different bins and for prognosis purposes and also for determining where to look for specific treatment. So patients with IDH mutated tumor, wow, we have to like seriously think about comprehensive genomic testing for fusion and stuff like that. Whereas wild type tumors, it may not be as important. Okay. So that helps your doctor to go in one direction or another. Yeah.
Outstanding. There are a lot of questions. They came in ahead of time as well as right now. Unfortunately, we're on a time situation. So one of the things we will be doing, Shreya will be sending out to all of you when we're done with this webinar and we've had time to edit it a little bit, and turn it into a patient disease educational video. She will send that out to you along with each of our presenters' email address, contact information, so that if you do continue to have questions, which is great, as you should, you will have contact information. And also know you can always utilize Shreya, our patient navigator and clinical trial coordinator, as well for any of your questions. She will, if she doesn't know the answer, she'll find out from the specialists like Dr. Wong, et cetera, et cetera. So what a wonderful, wonderful conversation today. Thank you, Dr. Wong.
Well, thank you for having me here.
Absolutely. Patients are very, very lucky to have you.